Welcome to this DDW session entitled Eosinophilic Esophagitis, Swallowing Made Simple. I'm Gary Falk for the University of Pennsylvania, and with me is my good friend and colleague Sandeep Gupta from University of Alabama, Birmingham. And this should be a very enjoyable session. Each speaker will have about 15 minutes with a minute or two for questions after that. And we're going to start first, get right into it, in making the diagnosis in 2025. Dr. Alan Khan from the Mayo Clinic, and as he's walking up here, I told him earlier today, in 40 years of going to DDW, he had the single funniest slide earlier in the week that I've ever seen at this meeting.
All right, well, thank you very much, Gary. Thank you to both of you, and thanks everyone for being here. I'm delighted to be a part of this very exciting session, and I think there's some excellent speakers and talks coming up. So I get the honor of starting us off with a diagnosis talk, making the diagnosis in 2025. So the goal today is really to review some general best principles about EOE diagnosis and incorporate some of the new science, focus on doing the best to make sure we're delivering the highest quality care to our patients with EOE, incorporating what we know now in the present time. Let's see if I can get this to advance. There we go. So as many of you know, EOE is frequently missed or misdiagnosed. Sometimes patients are mislabeled as having GERD, may even have overlapping GERD, and Dr. Vasey will talk to us about that shortly. And suspecting and ultimately diagnosing GERD is critically dependent on a proper clinical history. So we really have to start with a proper history before we can make a diagnosis of EOE. So starting with the epidemiology, we know this is a male-predominant disease, patients mean age in their 30s, but certainly we see patients who are much younger, even children, and all the way into older age. The presenting symptoms are quite variable. As many of you have experienced, the most common presenting symptoms are dysphagia and food bolus impaction, of which EOE makes up a large proportion. In addition to that, patients may present with things like chest pain. They may have symptoms that mirror what we see in GERD, things like heartburn and a sensation of regurgitation, and then a potpourri of other symptoms, less commonly things like abdominal pain, nausea, or vomiting. There is also often a concomitant atopic disease history. So patients may describe having things like asthma, allergic rhinitis, eczema, and these are important things to inquire about as you're taking a clinical history because it may tip your suspicion towards EOE. Again, as we're talking about this differentiation of EOE and a patient who maybe has GERD, these are the types of clues that may kind of tip you one way or the other, as Dr. Vasey will likely discuss. And so you put all this together and you develop a clinical suspicion for whether a patient might have EOE. Now, it's important when you're questioning a patient. Very often I'll be talking to a resident or a fellow who saw a patient, and they'll say, oh, the patient denies dysphagia or dinophagia. But if you just ask a patient, do you have trouble swallowing, or do you get things stuck, that is simply not enough to get a sense of what they're actually experiencing. So there's this helpful acronym called IMPACT, which describes the compensatory eating behaviors that patients often go through who have EOE. They just learn to live with this condition, which they may have had for years before the time you're seeing them, and they change the way that they act. So it's important to get a sense of, do they drink things differently? Do they avoid certain foods? Do they cut things up very small before they're eating? Are they the last one to eat whenever they're sitting down to eat? I hear that a lot from patients, and that's a question that really resonates with them. You might ask them and not hear anything, and then as you're asking these questions, you might come to realize they actually have a liquid diet. So do they chew excessively? What things do they avoid? So these are really important questions to get at, both in terms of guiding your suspicion of the disease, and then also just for tracking them moving forward. What kind of things are you now reintroducing? And you may actually have to really coach them and coax them into reintroducing things because they might be frightened of doing so. So this is a really important factor in understanding how to treat these patients. Now at this point, you've developed a suspicion for EOE and you want to do an endoscopy to obtain the diagnosis. So how do we make sure that we're performing the highest quality endoscopy and all the things that we need to do for our patients? And luckily, we have this excellent document that was just recently published this year and has very helpful indicators for the things we should be doing. So I'm going to go through each of them and talk about why we do them, what the rationale is. So first of all, we want to use the EREF score in our procedure documentation. So what is the EREF score? This is an endoscopic reference score developed by Dr. Iko Hirano and colleagues years ago, and it basically provides a framework for what are the features we should be describing in endoscopy and how should we be describing them. This is available in many of the procedure documentation software platforms, just inbuilt, but you can also obviously describe it yourself. And it provides a standardized way of assessing EOE severity and the features of EOE during endoscopy. So we look at things like edema, rings, exudates, furrows, and then the presence or absence of a stricture. The stricture obviously will need to be described further in your procedure report, the diameter, the location, multifocal strictures. Is it a smooth narrowing? Is there a single focal point? These are still really important details, but we need to capture these basic concepts in our endoscopy reports. Now, why do we use EREFs? Well, this is a study which looked at variability in the description of the global severity of EOE amongst 5 different experts. And you can see wide variability in the way these 5 experts described EOE globally in terms of severity. So when we start using EREFs, what we see in studies is that we see improved intra and inter-observer agreement. It provides much more comprehensive documentation of each of these individual features. It provides a standardized language that we can all use to describe what we're seeing, and then really gives us our best assessment of the treatment effect. So later on, when we're looking to see if patients have responded, certainly we want to see if they've responded histologically, symptomatically, but it is the most helpful way to know if endoscopically they're improving. So you can trust that you're doing this in a way that your colleagues are doing it. So that's the first recommendation. The second is to obtain a total of at least 6 biopsy samples, and importantly, to biopsy even if the exam is endoscopically normal. We know that anywhere from 10 to 30% of patients with EOE will have a normal appearing esophagus, depending on which study you read, and it's important to take biopsies regardless. So why do we need 6 biopsies? These are 3 different studies that have been done assessing this question. And as you go from 1 biopsy on the left to 6 biopsies on the right, you can see the diagnostic yield increasing. A couple of these studies, once they reached 5 biopsies, were essentially at almost 100%. 1 was not quite there. So once we got to 6 biopsies, we saw that there was this asymptote effect. After this, they all reached 100% diagnostic yield. Taking 7, 8, 10 biopsies didn't add any additional benefit. So taking 6 biopsies seems like the best number to take based on what we know. What else? Well, we should take biopsies at 2 levels of the esophagus, so in the distal esophagus and the mid and proximal esophagus. Again, why do we do this? Well, this is a study in which a patient had an esophagectomy and had EOE, and they systematically mapped the eosinophilia through the esophagus. I've added like a little gradation score down here so you can see that the blue is less than 3 EOs per high-powered field, the red is over 20, and everything in between. And you can see that the disease is extremely patchy through the esophagus. And so in order to provide an adequate diagnosis, we need to understand how it's distributed throughout the esophagus. In addition, we'll talk a little bit later in differentiating GERD and EOE. It's important to understand the distribution of eosinophilia. Now, one question that I've always had, I don't know how many of you have had it, but I always wondered, what is the distal esophagus? What do they mean? So here are 5 studies describing what they mean by distal esophagus, and I think there's a fairly broad consensus. We're talking about the distal 2 to 5 centimeters of the esophagus. Now, importantly, we're not talking a bit about the GE junction, so you don't need to take GE junction biopsies when you're looking for EOE. This is in the body of the esophagus, so it does not involve the stomach. What else? We should be targeting areas of visible abnormalities. So when you're taking biopsies, really try to target those areas that look the most like EOE. Why would we do this? Well, here's a study from Kathy Peterson and colleagues where they actually looked at the distribution of eosinophilia based on the endoscopic features. And not surprisingly, when we saw plaques and furrows and we biopsy those areas, we see a higher number of eosinophils in the biopsy. So if you want to really standardize and make sure you're getting the most accurate information, try to target those areas of visible abnormalities. These things are not in the guidance document I just shared with you, but just some suggestions I have. Probably good to separate jars at the initial diagnosis. Certainly after you take your initial biopsies and you're following a patient over time, once you feel confident of the diagnosis, you don't necessarily need to separate the jars based on the location, but you still need a biopsy throughout the esophagus. And also probably good to initially do your EGD off of PPI therapy after a washout. Why do we recommend that? Well, again, as Dr. Vasey will discuss, there is some confusion about the overlap between these diagnoses, and he will go into that in much further detail. So now you've done your endoscopy, you've taken your biopsies. What do we do with that information? What do we do with the biopsies that we obtain? Well, I think a lot of us conceptualize of how we evaluate these biopsies just based on what we consider the peak eosinophil count. So I'll use this concept PEC, you'll see, for peak eosinophil count. But it turns out that there's a lot more to the biopsy evaluation than just looking for the peak eosinophil count. There are things like eosinophilic microabscesses, dilated intracellular spaces, basal zone hyperplasia, and all kinds of histologic features that our colleagues in pathology notice when they're looking at these specimens, and that adds something to our understanding of what's going on with the disease. So how can we incorporate that into our assessment beyond just the peak eosinophil count? And really, should we be doing that? Well, in 2017, a group of pathologists looked at this, and they took all of these various histologic parameters, and they put them into a composite score and compared that to the peak eosinophil count to see if it added some value. And it turns out that it does. So they developed this thing called the EOE histologic scoring system, EOE HSS for short. And it takes the peak eosinophil count, and then it adds these additional features that are scored according to grade and stage on a Likert scale from 0 to 4. And that yields this composite score. So what do we know about the EOE HSS? Again, this has only been out there for about 7 or 8 years now. And studies have shown that it exhibits near perfect intra-rater and inter-rater reliability, which is obviously very good. We also know from studies that the HSS grade and stage perform better than peak eosinophil count for global histology disease severity. So it better describes the global severity of the biopsies. And also correlates better with the EREF score, with the actual endoscopic features of the disease than the peak eosinophil count. So overall, it seems like EOE HSS is adding some additional value. I don't think we quite know exactly where this is going to fit in, but I think peak eosinophil count clearly both under and overestimates disease. And you can imagine a situation, and we got this question during a session I gave the other day, where someone said, well, what if you take care of a patient and they're doing very well clinically, their endoscopic exam is better, their symptoms are better, but there's still some residual eosinophilia or something like that. Well, you could imagine that knowing their EOE HSS might provide some additional reassurance that some of these other features have gotten better. And we need more data to understand how that fits in. But just know about this, because I really believe this is coming, and it's something that's going to be a part of our assessment of this disease. So moving on from that, now let's say you've made the diagnosis now. Well, what else is coming in terms of diagnosis of EOE? Well, we need to talk a little bit about alternative tissue collection methods, because I think this is something that we get asked about and something that we need to be aware of. So there is something called an esophageal string test. This has been published about a little over the last 5 years or so. And this is a study that was developed initially to place this string. It's a string that sits in the esophagus and collects tissue. Initially was left in there for a day, and a subsequent evaluation of that test showed that it could be done for an hour and yield comparable results. And so obviously that is preferable. Basically, the patient swallows it, or remains in place, then it's pulled out, and it's assessed for these eosinophil-associated proteins, so these markers of eosinophilic inflammation. There has now been a prospective study in which the eosinophil-associated proteins were compared to basically the results of peak eosinophil count on biopsies. And on the right, you can see the area under the curve is fairly comparable for these eosinophil-associated proteins and the biopsy results yielding the peak eosinophil count. So high correlation. Patients really preferred this to endoscopy, assuming, of course, we could obtain similar information, which overall it seems to be the case. Importantly, about 14% were unable to complete the test. And then, of course, this does not give us any endoscopic features of the disease, things like strictures and things we'd want to know about that. So that's an important limitation, but I do think this is an important thing to be aware of and something that may become more mainstream at some point. The next thing we'll talk about is the cytosponge. So this is a polyurethane sponge that's contained within a capsule that melts when it comes in contact with the gastric acid, and then the sponge is then deployed and pulled up through the esophagus, kind of scraping the tissue off that can be collected, spun down, and reviewed like a cytology specimen. It's been used in other applications, Barrett's esophagus and other situations, but there's always been an interest in, could we do non-invasive screening, could we do non-invasive surveillance of patients with EOE? And certainly our patients want to know if that's a possibility. The initial feasibility study, this is a prospective study that Dave Katzka and others did, showed that the test was very safe. 7% failed, but for the most part everyone was able to do it. There were not any major adverse effects of the test, very well tolerated. Did very well in diagnostic accuracy. So area under the curve was almost, is 0.87. and patients preferred it to endoscopy, had very favorable scores. So I think for initial diagnosis, this was promising. There have been subsequent studies now, one at least, that evaluated this in a setting where I think many of us would wonder if it's useful, and this is in the reintroduction phase of the food elimination diet, and unfortunately showed that the agreement between the sponge and the biopsies was only 59%, so suboptimal and not what we'd like to see. Clearly, as the peak eosinophil count rose, we had missed things in that process. So, it's not clear yet whether this is something that's going to become a part of our practices, but I suspect that we will need to continue to reevaluate this because patients certainly want to find a way to do things non-invasively. Transnasal endoscopy has been around a long time. It's certainly not non-invasive, but it provides some benefits. It's performed outpatient. You basically spray the nostrils and insert it. It's done often in children. Here you can see a child with a virtual reality goggles to distract them and kind of get them through the procedure. Very quick. Was first assessed in 2016, and only 25% of patients were willing to undergo it, but had high satisfaction. A subsequent study was done in a much larger group, basically showing it was highly technically successful, had adequate histologic specimens, very fast in terms of patients were in and out very quickly and reduced cost. So that's very favorable. And then last comment I want to make is the role of the esophagram. I think sometimes we don't talk enough about this, but this is my own personal opinion and practice. But I think it's very valuable to obtain esophagams at baseline for new diagnoses. Allows us to assess for subtle stenosis, allows us to get a baseline for future comparison. For me, I think it facilitates an adequate and safe dilation in a patient with a stricture that we may not appreciate on endoscopy. And then if patients come back later and there's a change in symptoms, it's a nice non-invasive way to assess if things have changed without needing to get an endoscopy right off the bat. So I think it does have a role and should also be included. So in conclusion, I think you need to have a very careful history when you're assessing a patient for possible EOE. Be aware of these quality metrics and the things we need to be doing to bring the best quality to endoscopy. Be aware of the EOE HSS and its evolving role. And then let's keep an eye out for some of these alternative tissue collection practices that may change our practice. So thank you very much and enjoy the rest of the session.
We have time for one question. And there are seats in the front and scattered throughout so people don't have to stand. If there's no questions, the only thing I would ask, you want to comment about the issue of making the diagnosis at the time of food impaction?
Oh, at the time of food impaction?
Yeah.
Yeah, I mean, I know there's some controversy about this. I mean, to me, it seems so intuitive. Like when I will tell you, and I have fellows of mine are in the room, that when I come in and do a food impaction case in the middle of the night and I remove the food, unless there's some really, awful looking, disruption or something that looks like really we could cause more damage by spending more time, I'm always assessing for dilation and frequently dilating, and I'm always taking biopsies at the time of the food bolus impaction. There are data now showing that this is safe, and that's a good way to capture patients at the time that they're there in front of you. Who knows what will happen when they leave? They might not be able to come back. They might live far away. There's all kinds of barriers to them returning. So you might as well get the most out of that you can. So I encourage all of you to do that.
Just a quick question from the raise of hands. How many of you do you use EREFs in your practice? About 40%? Okay, thank you.
Thanks.
Our next speaker is Dr. Michael Vasey from Vanderbilt. He'll talk on is it EOE, GERD, or both? Dr. Vasey.
Thank you so much. Good morning, everybody. When you get older, you become more of a forest than a tree. So I'm going to give you a forest view. If you want the tree, I'm happy to discuss it. But I think the forest view might give you a better answer to the question that was posed. So I was asked, let me my slide come on. Is it EOE, GERD, or both? I only have one slide. There's my answer. Thank you very much. All right. So let me give you my disclosures before I go into it. It's an interesting question, but I'm going to approach it more from a clinician, an adult gastroenterologist. So I apologize to my pediatric colleagues because it may or may not apply to you. If it does, I hope it's helpful. If it doesn't, I'm sorry. So GERD linked to eosinophilia. We know that reflux causes eosinophilia. No one here would disagree with that, right? So the question is not whether reflux causes eosinophilia, because there are different mechanisms. We know in patients with esophagitis, if you biopsy it, you're going to have some eosinophils. There's correlation with degree of reflux, distal and proximal, acid peptic alteration in the epithelium, cytokine-mediated mechanism. All of that is established. And then the thought is that perhaps this would be less than 20. So I'm going to comment on less than 20, more than 20, or more than 15, less than 15. These dichotomous measurements are begged and borrowed from our pediatric colleagues because they saw this a long time before adult gastroenterologists saw it. This was correlation with the degree of reflux that's based on a certain cutoff parameter that I'll highlight. But the point being, this was something that we agree with. GERD links to eosinophilia. It causes eosinophilia. Now, we also know that EOE causes eosinophilia by definition, right? So that's an easy one. So there are a variety of correlations, and the thought is that this group would be more than 20. But then why is it that if the distinction is so good that if someone has less than 20, it's GERD, if it's more than 20, it's EOE. Why is it in clinical practice I'm seeing so many patients that are diagnosed with EOE that don't have it? And they solely base that on eosinophil counts. So that's not the answer. We know that because that's where the dilemma is. So then we know that there's some PPI responsiveness to both. We know if you do pH testing, 25 to 50% of patients have abnormal pH. By the way, again, our pediatric colleagues were very helpful in showing us this in that group. So then we said, if that's the case, this is really GERD, so let's really just say EOE is not those that respond to PPIs. That was the initial AGA and Aspergan diagnosis in 2007 that says to be EOE, you have to not have abnormal pH or esophagitis, right, or respond to PPIs. So this was GERD, this was EOE. Simple. Then we said, wait a minute, what if GERD causes EOE and we're excluding this group artificially and we shouldn't be doing it? And there was this discussion of GERD and EOE link. So we know GERD causes eosinophilia. We talked about that, no argument. What if GERD and EOE coexist? That was an argument. There's also potential for EOE causing GERD. And the thought is through VIP and relaxation of the LES, maybe EOE is actually causal to it. And finally, the question at hand, GERD causing EOE. And that's through dilated intercellular space. These are the mechanisms through which this argument is going back and forth. So because of that, we said, well, let's not call that GERD, call this PPI responsive EOE. So it's really EOE, it's just PPI responsive EOE, yet let's bring that back in, call them EOE, not GERD. And then we said, well, is that true? Then agree consensus came about, right? For those of you that were there, we agreed on this. So we said, well, acid could cause dilated intercellular spaces through which you could have antigen exposure, through which you could have eosinophilia. So GERD could cause eosinophilic esophagitis. And then that would lead to all of this cascade of things that we're familiar with, adults and pediatrics, and that's EOE. So everything's clear so far, right? All right, so let's explore this a bit. Abnormal pH, so this is GERD. I'm not sure. Again, select number of patients, not a whole lot of adult populations we have data on, and if we look at those studies, they use pH 4.2 as the cutoff. We already know about this dilemma of reflux. Is it 4? Is it 5? Is it 6? Is it 8? Is it 10? Is it conclusive? Is it supportive? I'm confused. So this is confusing me as someone that treats reflux, right? Now, this created more confusion for us in the EOE community in caring for our patients. So acid exposure and the EOE cutoff was based on pH parameters of 4.2 as the cutoff. And we know that That may not be right. In fact, Dr. Patel in my group has abstract at DDW that says maybe the cutoff should be 10 because those cutoffs were from 1978 and 1980s when we weren't so, I shouldn't say large, but I'll say obese. So the obesity rate has changed, perhaps the cutoff should change. So maybe that's not quite accurate. And also we know that the correlation to EOE count is not perfect with the pH. So I'm not convinced that that's a good argument that reflux because of pH abnormality is causal to EOE. Now let's explore this then. Why couldn't we just say that reflux is reflux, EOE is EOE, and they both respond to PPIs? And they do that through a different mechanism, right? So one is acid suppression, the other is anti-inflammatory properties or other mechanisms. When we did a randomized control study of patients with sinusitis, this was many years ago, 2007, published that it was a positive study showing PPIs responded. The patients responded to PPIs with chronic sinusitis. We were very careful to highlight that this may not be due to acid suppression. It may be due to anti-inflammatory properties. So could one just say that they're just different? That it doesn't have to be that GERD is causal to EOE. The reason that's important is, as I was highlighted with the first talk, we got to look at the phenotype of the patients to reduce complexity. GERD causes eosinophilia, sure, but that's GERD. That's an easy one. Going down here, GERD causing EOE, that's a different question. That presumes that young males somehow started developing reflux to an extent, and again, I'm talking not pediatrics, adults, that the rate of reflux in that group went so high that they have reflux and that's causing their EOE. So it doesn't fit the demographics of the patients. So we can't forget demography, we can't forget endoscopy or pH. So for me, as a clinician, someone that takes care of patients, I think the confusion in EOE that's around and the patients that I see are because they're overdiagnosed. They're biopsying the distal esophagus, they're finding EOE, and they're saying this is eosinophilic esophagitis. Why? Because we told them that's how we should diagnose the patient. So it's just a question, is that the right way to diagnose? If I biopsy distal esophagus, mix it with proximal esophagus, my pathologist looks at it and says, yes, there's eosinophilia, a GERD or an echolalia patient could have EOE. But we know that's not the case. They're separate phenotypes. So this idea of cutoffs is problematic. And I know this is sacrilege talking to a group of EOE experts here, but maybe we should relook at it differently. This is a pathology, panesophageal disease that alters the epithelium and there's inflammation. That inflammation causes dilated intercellular spaces. The epithelium is abnormal. That's it. So can we diagnose it differently? So what if you use mucosal integrity testing and you see that there's panesophageal alteration in the epithelium and you're done? Or you don't. You have distal esophageal abnormality and proximal normal, and that's your EOE versus GERD, rather than a cutoff at a specific point or a combination of points. We know that using that, biopsies alone misclassify patients with EOE, 25% misclassification. This is an abstract this year's DDW. I encourage you guys to go see that. We also know that MI correlates with peak eosinophil count. So I'm just throwing this idea out that maybe we should look at it slightly differently to reduce complexity. What about symptoms? We know how good symptoms are. Symptoms you can't rely on, and we heard that earlier. Dysphagia is easy, right? But heartburn. We publish papers that say you could have heartburn, but it could be EOE. And that's the only presentation. And if you biopsy the distal esophagus and it's abnormal, it's EOE. Maybe it's GERD, because we know heartburn is better for that, right? Dysphagia. So let's not forget that. What if this patient you saw? Would you question if that's EOE? Do I have to biopsy this patient to tell you it's EOE? Well, you're telling me yes, because the guidelines say biopsy, more than 20. Food impaction, dysphagia, young male. It's EOE. You have your endoscopic appearance, right? So thoughtfulness. What if you biopsy this patient? This was a patient that was sent to us from another well-known academic place with a diagnosis of EOE and on steroids and other therapies. This patient had distal esophageal eosinophilia and heartburn, some dysphagia. This was GERD. So we're misclassifying because the phenotype didn't fit, 60-year-old male. What about this one? 65-year-old female, dysphagia, yes, panesophageal narrowing, and then when you scope, you see rings, panesophageal. You go, wait, endoscopy says it may be EOE, phenotype doesn't fit. This is lichenoid esophagus. So not all is EOE, right? This is lichenoid esophagus. So one has to be thoughtful. So I'll just leave you with 3 or 4 more slides I have, and it's really simple, at least what I use clinically in the adult population. Is it EOE? Yeah. If symptoms fit, if demographics fit, if your endoscopy fits, if your histology, and if you want to do mucosal integrity, if it fits, then it fits. But it's not if 1 or 2 of those don't fit. So we're so used to using a technique for a diagnosis, more than 15, less than 15. We have to be careful. We've created this animal of confusion, if you will, or is it GERD, isn't it GERD? Maybe it's GERD and it's EOE, so we got to be careful. And this is GERD. If it fits the demography, endoscopy, pH, everything has to fit. We got to use it together. So I say, is it GERD, is it EOE? It could be separate. And to me, clinically, I use those parameters that I mentioned to make the diagnosis, to reduce confusion, but again, a forest rather than a tree approach. So my last slide, take-home messages. Presenting symptoms are important. Endoscopy, histology, physiologic testing in isolation may be misleading. Endoscopy may be normal or show other panesophageal diseases, but yet if you rely on biopsy, you're going to be misled. pH testing is static in nature, and it's a cutoff base, and be careful with that. And don't just say because it's abnormal, it's GERD, and ignore everything else. Histology obviously has limitation because it's patchy. After you treat a patient, you biopsy, it's normal, but patient still has symptoms. Maybe it's the patchiness because we're using biopsy alone to make the diagnosis. And finally, taken together, testing may explain presenting symptoms for accurate diagnosis. Use it all together, at least as a clinician, that's what I do. I hope that was helpful. Thank you.
Just a reminder, there are a bunch of seats in the front and scattered around. Please take a time to get a seat for yourself. This presentation is open to questions. Please introduce yourself. Introduce yourself also.
Sami Adib from Austin, Texas. Great presentation. I have a question. A lot of time, the patient will already come to us while on PPI trial. Would you do the endoscopy and the biopsy off PPI, or it's okay to do it on PPI?
Yeah, so the question becomes, if you did or didn't hear it, if a patient comes to you on PPI trial, if you will, the key is go back to what is the symptom that the patient presented with for which they're on PPIs. If they're given a diagnosis of EOE and now they're still symptomatic and you do your endoscopy on PPI and it's normal, then it's one of 2 possibilities. It was an EOE that responded to PPIs, the group, or it was GERD that responded to PPI. But if the patient continues to be symptomatic, the mucosa continues to be abnormal, you obviously are going to do other diagnostic tests such as biopsy, maybe mucosal integrity, to get to the diagnosis you need, because obviously PPIs weren't enough. Now you got to step forward for other therapies. Yeah. So either way is okay, off or on, it's semantics, but using all of it together, at least that's what I do, it makes it easier for me to categorize the patients.
So, Mike, what about the 26-year-old with a 3-centimeter hiatal hernia, atopic symptoms, multiple features on the EREFs? How do you handle that person? Wide open LAS, but has got atopy and lots of other things going on.
Yeah, so again, the question becomes which, when you're looking at GERD versus that, if I do endoscopy and the endoscopy shows hernia but no mucosal irregularity, that's a different one. If EREF is really abnormal, then it's telling me that it's likely EOE, right? So hernia by itself is a permissive pathology, i.e. it allows reflux to happen, but that doesn't necessarily tell me that it's causal to EOE. It just says there's a hernia. I have a hernia. You might have a hernia, and you may not have reflux or EOE. So by themselves, it doesn't help. But if EREFS is abnormal, then I would say most likely it's EOE.
But they can have both too, right?
So if a
You gotta say, it's a yes,
32-year-old...
that's a yes/no question.
Yes. I'm in Washington, I'm being questioned. So there is no yes/no in that. It is hard. You have to really take it. They both coexist in a 32-year-old. Do you have a patient who's 32 that has reflux? Absolutely. But look at the predominance of it, right? GERD is not predominantly in a thin 32-year-old. Less likely. We've all had those patients. GERD is most likely related to older patients, middle-aged to older, larger BMI, maybe hernia. But they could coexist, but again, I'm going by probabilities.
Thanks so much.
Yeah, thank you.
Thank you.
Okay, so our next talk is going to be given by Dusty Carlson from Northwestern on tools to assess severity of EOE, which is an emerging, very important concept for all of us. Take it away, Dusty.
All right. Well, thank you so much, Gary. Thanks to the AGA and the organizers for allowing me to speak in this awesome session. And really, thank you to some of my co-speakers for setting the table very, very nicely. So we started by talking some of the concepts about EOE, yes or no. But now I get the opportunity to talk about when we know we have EOE, how do we now look at it on a spectrum of severity? Because that is one thing with EOE is that there is a spectrum. Some people are more affected and affected in some ways than more than others. Let's see. So that's what we'll go through here over the next 15 minutes. All right, a couple of disclosures. But first off, why? Really, when we look at this, we try to find the degree of impact on a patient's life with regard to symptoms and quality of life. We certainly want to qualify and look for a risk of food impaction. Who do we have to cautious more on diet, and who do we maybe need to treat more aggressively? When it comes to that directing management standpoint, who do we need to be more aggressive from a dietary medical standpoint? Maybe who needs endoscopic therapy and needs dilation? And then ultimately, we really want to learn about this disease. We want to monitor disease progression. We want to monitor outcomes in our clinical studies. And all of this is what we're using to assess severity in EOE. Now, when it comes to how, part of what we want to look for is to make sure we have ways that are standardizable, ways that are generalizable, so we can compare these outcomes between different centers, between clinical studies where we have data and apply them in our own clinical practices. And often this looks at in a set of these three primary domains with symptoms, endoscopy, and histology. Now, recently a composite score has been introduced called the Index of Severity in EOE, or the IC, and it brings these features together, bringing symptoms and complications, bringing inflammatory features that are identified both on endoscopy or histology, but also bringing in these fibrostenotic features also from endoscopy and histology. And this can be scored and actually supplemented by an app that is available for download and use on your phone. But using this score, the IC can actually classify patients into these four categories of inactive, mild, moderate, or severe disease. And nice study from the UNC group looked at this and showed that the IC score is actually modifiable. So after treatment, the IC score will go down. It may have variable rates depending on the baseline IC score category. Now, each of these symptoms, I think really one of the key goals of this composite is that it brings all these different facets together, because in isolation, all of these different domains have some issues. But even here, we can see that this does track with some other important disease features. So as I mentioned, there was that app. Here's what it looks like. And you could take an example from this patient here. 37-year-old, was in ER for a food impaction a couple of years ago, wasn't dilated, now avoids gluten and is actually doing okay, dysphagia a couple times a week. Gets an EGD, narrow caliber esophagus. EREF score is displayed here as well. And on biopsies has over 100 EOs per high power field. You can plug all this in. It spits out a score. This patient has a score of 11 that has moderate disease. So let's look at these different domains each individually, though, and kind of see where maybe some of the features in isolation do fall short. So this is the line that's the lead into most papers with EOE, or at least something similar. And so naturally, the symptoms are a big part, an important component here in EOE. This is the patient experience. This is what we're trying to make people feel better, and so of course symptoms are important. Something to note is that symptoms differ depending on the age of presentation. We've talked a lot about dysphagia, we think a lot about dysphagia, but as my two co-speakers mentioned leading in, is that there can be some discrepancy here in the adult population, and even more so in the pediatric population, where kids may not demonstrate or describe dysphagia, but maybe more like abdominal pain. So not even symptoms that localize to the esophagus. Now there's multiple tools that are used, validated patient-reported outcomes that look at trying to quantify the severity of dysphagia. And this is not an all-inclusive list by any means here, but a couple commonly used ones. But no matter what we use, and really no matter how we assess symptoms, alone they are inadequate to really assess disease activity. And this has been borne out, I think makes common sense, but been shown in a number of studies. And here's a nice study that used this ESI, which is a pretty comprehensive tool, but still showed that if you look at this and try to look at other components of EOE disease activity, the sensitivity or specificity for symptoms alone really tells you very little about the activity of EOE when it comes to other objective outcomes. And there's multiple reasons for this, and one is Dr. Khan led into is just the idea of these adaptive eating behaviors that people do, and the impact mnemonic helps display these very well. What's sometimes a challenge is the patients often don't even realize they're doing these. There can be these subconscious behaviors that really do drive some of this. Now, if you talk to a patient, they say, I'm not having any dysphagia, and then they tell you that all they're eating is soup, you frame that a little bit differently. Now, if a patient doesn't want to eat bread or doesn't want to eat steak and they really like soup, does that mean that their EOE is really severe? Symptoms in isolation are inadequate. The other factor, though, that weighs in here is actually the degree of hypervigilance and anxiety. And we do know, and actually we did a study a few years ago where we looked at this using a validated measure called the EHAS, or Esophageal Hypervigilance and Anxiety Scale. And we showed that this EHAS score was the strongest predictor of symptom severity in EOE patients, stronger than eosinophil count, stronger than EREF score, stronger than endoflip metrics. And this makes sense. And this isn't telling patients that this is all in your head. This is the experience where these other factors of hypervigilance and anxiety really mediate how patients experience the environment. And having a food bolus stuck in their esophagus, people are going to be more vigilant or more anxious about that. And there is a point here where vigilance to some degree is going to be protective. This is what keeps a lot of our patients out of the emergency room, is by being vigilant and chewing their food well. There becomes a point, though, where that crosses over a line and becomes more pathologic. All right, but I'll move on to histology. This is the other key feature that's in this lead-in line to most EOE papers. And often here we look at the eosinophil count. And both Dr. Vasey and Dr. Khan talked about this at length, but using typically this threshold. There's always limitations with thresholds, but this is used as a diagnostic criteria, but also as one of the key outcomes in pretty much every EOE trial. But again, while eosinophil count is a very important measure and a very important feature of the inflammatory components of EOE, it also doesn't consistently correlate with some of these other outcome measures. And I think if we take some lessons learned from some of these recent clinical trials from the anti-IL-5 benralizumab, and this has been shown in actually multiple clinical studies, where even with profound reduction in eosinophil count, we don't see dramatic differences in dysphagia using a validated dysphagia score. So eosinophil count, important, but not the whole story. And maybe it does come into some of these other features. And Dr. Khan talked about the histologic scoring system that was described by Margaret Collins, and it looks at some of these other features that start to look at remodeling. And same study that's already been shown here, but this can actually track better than peak eosinophil count when it comes to looking at treatment status in a number of patients. So something to think about beyond the eosinophil count. Now, how about with endoscopy? Now, naturally, we're doing endoscopy in our EOE patients, and this is an essential component to both make that diagnosis, to rule out other conditions, collect biopsies, also an opportunity for dilation when clinically appropriate. And when we're doing endoscopy, that is a chance to actually be diagnostic as well. And we've talked about the EREF score. Really has become a quality measure and the standardized reporting tool for looking at these key features in EOE. This has been shown before, looking at these 5 features, and more importantly, this also can be looked at with regards to inflammatory features, being the being the edema, exudate, and furrows, compared to the fibrotic features being rings and strictures. So this does help to look at some more of the underlying mechanisms that are involved and maybe driving severity in EOE. Now, some challenges come with this as well. One question that often comes up is, what is the relevant EOE threshold or the EREF threshold that should indicate maybe less severe than severe disease? And some work from UNC suggested that an EREF score less than 3 did have some association with histologic and symptomatic outcomes, but yet we still quite don't know what the ideal change score is. But also, I think when you look at endoscopy and some endoscopic limitations, it comes to trying to estimate the degree of narrowing on strictures. And we've seen a lot of discordance here. Dr. Khan talked about esophagram and using that to assess stricture. And there was a study from the Mayo sites looking at endoscopy compared to esophagram and showed that endoscopy was very often missing stricture, at least when it was compared to esophagram. But with esophagram, we also worry to some degrees that there may be underdistension here. And as the bolus in the swallowed barium study is passing through the esophagus, it may not actually be distending the esophagus, and so may overestimate the degree of narrowing. Not to mention here, this is an additional visit for a patient. They have to get an additional test outside of endoscopy, and so while it can help direct dilation, there is that temporal disconnect that can add a little bit of some lack of convenience for patients. So with a few remaining slides, I'll maybe pose that we add a fourth domain of severity in EOE. And the only thing Gary asked me in this talk was to not talk about just FLIP, so I've hopefully done that okay to some degree. But I will talk about FLIP now, because I do think that FLIP offers us another opportunity to make our endoscopy and make that endoscopy encounter a little bit more enhanced. Because FLIP is done during a sedated endoscopy, so convenient for patients, comfortable for patients. There's a volume-controlled distension protocol that can be done, which usually in about 3 to 5 minutes. And it allows the positioning of a FLIP within the esophagus. And FLIP uses a technology called impedance planimetry, which can measure the dimensions of a bag that's filled with fluid during the study protocol, but also incorporates a pressure sensor inside this bag, so it can look at this relationship between the dimensions of the esophageal body and pressure. But even more than that, we can plot this over time. We can actually look at dynamic esophageal motility here, and we can see this normal response here where there is a repetitive secondary peristalsis that occurs. And so this is where we've come up with this term of FLIP panometry, indicating that we can get multiple metrics, a panometric assessment of esophageal function here, looking at the mechanical properties of the esophageal body, looking at anatomy and lumen dimensions, and also bringing in motility all to the endoscopy suite. We know that there are many physiomechanical consequences that occur in EOE. It's associated with reduced distensibility of the esophageal body, and reduced distensibility of the esophageal body carries a strong association with food impaction. This study from 2013 looked at this and actually found that distensibility plateau, or the narrowest diameter within the esophageal body, less than 17, was associated with a risk of food impaction, a risk for dilation, as well as for persisting symptoms. But recently, we've taken this a step farther, and we've tried to bring in these multiple components that we get during the FLIP panometry assessment with endoscopy to look at distensibility. And here we can look at distensibility beyond more a single measure, but can really quantify the degree of narrowing, but also the extent of narrowing by using the distensibility and compliance of the esophageal body, as well as at the esophagogastric junction. And then we can incorporate contractility as well. And we can look at this to really help objectively define this range of severity across the EOE spectrum. And we see that this range of severity actually tracks with a number of other clinical outcomes and clinical features of EOE. Increased duration disease being greater with people with more severe disease, more frequent stricture presence, and higher risk of ring severity. And also very interesting is that when you get to the more severe stages of EOE, chance of response to PPI is very, very low, about 10%. Whereas in other groups, especially those that have isolated reduced distensibility to EGJ, PPI response rates are about 90% in a small subset of patients that we've studied. So opportunities here as well, and I think this can help complement this overall global assessment of how we're tracking severity in EOE. So just returning to our same patient that I talked about earlier, had an IC score of 11. Here is endoflip data that took about 3 minutes during the endoscopy. We can see here that there's multiple measures of the EGJ at this point. Here, halfway through the study, we've pulled the flip back so we can measure both the distal esophagus here. Oh, I'm not getting my cursor. Distal esophagus here. Pull back the flip, we measure the proximal esophagus here. See the distensibility plateau in the proximal esophagus of 12 millimeters. We can see that there is some contractility present. This gives us a Hirano classification phenotype of fibrostenosis with normal reactivity. And then ultimately identifying these two areas of narrowing of 12 millimeters, we dilate to 39 French using a bougie and get a nice responsive stricture. So in conclusion, talk about assessing the severity of EOE, really using this to help guide and monitor EOE disease management. The IC score is a very nice comprehensive approach to integrate these multiple domains of disease severity. When it comes to symptoms, though, we do need to consider the impact of adaptive behaviors and also anxiety and hypervigilance. When it comes to histology, it's probably more beyond the eosinophil count, and I think we'll work to see that used hopefully more and more in clinical and research practice. Endoscopy, it's the ERIF score as well as stricture estimation. And here we can bring in some of the other components of physiomechanical function. We can quantify remodeling, incorporate motility, and then define these phenotypes. So with that, I'll conclude. Thank you for your attention and welcome questions.
Questions for Dr. Carlson? Dusty, just help the audience understand where clinical application, the gradation from clinical versus research application to FLIP applies today, middle of 2025 in EOE.
Yeah, I think that's a great question. And obviously there's been some increased use and adoption of FLIP. And I think in the current practice, it's not at the point where I think every EOE patient needs an EndoFlip. I think there's use there in a lot of sense to grade the severity and look for strictures. But I think certainly at least in that patient who you've done all the traditional therapies, you seem to have their eosinophil count under control, and they're still having dysphagia, often we're doing an additional endoscopy in that scenario anyway to look for subtle stricture and possibly to do dilation. And I think FLIP just really fits in there to help look for these added features, see if there maybe is a dysmotility component, to get more objective measurements of that's remodeling that may be impacting that disease state. And I think there can really help direct if there is need for escalation of therapy that maybe wasn't detected with our traditional measures.
And you want to comment also the time duration for the novice versus the expert for FLIP as the learning curve?
Yeah, I think, FLIP we've tried to standardize the protocol, and at this point, positioning the FLIP is very easy in the esophagus. Setting up the FLIP is usually done ahead of time, so it can be done by support staff in the endoscopy suite. The whole procedure of doing FLIP from start to finish is usually within about 4 to 5 minutes, and I think that, that can be something that's done. Placing the FLIP is very easy. Anybody who's placed a Bravo capsule can place an EndoFlip, so it is quite easy to get into the esophagus.
Any other questions? If not, thank you so much, Dr. Carlson.
My pleasure.
Our next speaker is Dr. Jennifer Halsey Silva from Mayo Clinic, and she will discuss how to dilate safely and effectively for EOE strictures. Use the mouse and hit the start button on the top bar.
Sorry, where? Oh, got it. It's coming. Good morning. I'd like to thank the moderators. This is actually the wrong slideshow, though. It's not on me. Yeah, there we go. So I guess to start off, how many of you actually do dilations in clinical practice for EOE patients? Okay, a lot of people. Okay, great. So hopefully I'll provide some more insight, but you may actually already be experts at this. So let's talk about this a little bit. So I'm going to talk about how to dilate safely and effectively for EOE strictures. And I guess what I should have asked is, how many of you are apprehensive to dilate your EOE patients? Anyone? Okay, okay, fair enough. So these are my disclosures. And I'll start by just saying that dilation is recommended as treatment for esophageal strictures causing dysphagia in EOE. There's no doubt about this. ASGE guideline or consensus statement and also recent ACG guidelines published just this year comment on this. It improves esophageal caliber. It provides immediate relief from dysphagia. It decreases a patient's risk of food impaction. So no doubt that we should be using this in our clinical practice. And it can also be done with inflammatory activity present. So studies have shown no difference in adverse events based on disease activity level. So I don't want you to be apprehensive to do a dilation in a patient that still has histologic activity. It is determined to be safe, and we know this from details in systematic reviews and meta-analyses. So there's been 2 that looked at rates of complications. Post-procedural hospitalization is less than 1%. Clinical significant hemorrhage, less than 0.5%, perforation, less than 0.5%, and none in these studies had surgical intervention or mortality. And note that chest pain can occur, and chest pain can be part of the normal procedure. So I counsel my patients when I'm going to dilate them that you may have chest pain after this procedure. Depending on what study you look at, some have quoted up to 25%, and if you look at just chest pressure, some even reported up to 40%. Now, I do want to pause here and say that worsening pain, shortness of breath, fever, chills are not expected outcomes of dilation, and so kind of keep that in your mind if a patient does complain of that. That warrants further investigation. And we also know that dilation is effective therapy, and it has substantial duration. So this is a forest plot from a systematic review and meta-analysis that was done by Dr. Moad and looked at 27 studies, including 845 patients. Out of those, dilation was associated with clinical improvement in 95% of the cases, and median duration of outcome or improvement was around 12 months. So it works. However, I'll pause here and say we do have limitations. So as mentioned already, we are fabulous at endoscopy. Everybody's here is doing dilations, but detection of strictures, I'll caution you, can be challenging. The small caliber of the endoscope and the wide field of view of the camera can be misleading. You need to fully insufflate, gently wash the debris off if there's some, allow sufficient time to investigate the esophagus. An assessment of esophageal diameter has poor inter-rater reliability. So this has already been mentioned with esophagograms, but I was just going to mention it further here, that endoscopy can have less than 25% sensitivity, that beautiful study that was done at a Mayo Clinic Rochester, for detecting less than 15 millimeter diameter narrowing when compared to esophagram. And another study in children noted that 55% of strictures on esophagram were missed in endoscopy. So if you have a patient who you've scoped and you do not think they have a stricture, but they are still having dysphagia, you still need to have stricture on your radar. So as mentioned already, esophagram can help, and I use it as an adjunct sometimes. So it can estimate your overall burden of fibrosis, including esophageal diameter. It can identify subtle or long diffuse strictures or even features that have been missed on EGD, and it can also help with your dilation planning. And it's non-invasive, relatively low cost, and available at most centers. I won't go into further detail about EndoFlip because Dr. Carlson already reviewed that, but this also can be used to look at diameter as well during your endoscopy if you think you might be missing a subtle stricture. So these are just some images of my patients that have undergone an esophagram. And so in the first one here on your left, you can see a barium tablet lodged in the upper esophagus. In that middle image here, you can see trachealization or ringing of the esophagus, or ringed esophagus. And then on the right here, you can see a narrow caliber esophagus. And I'll just pause here for anyone who's ordering esophagograms. You should order it with a pill to assess retention because it increases your sensitivity. So what should our endpoint be with dilation? So you found a stricture, you decide that you should dilate, where do you go from here? Well, what's been determined is that mucosal disruption or your dilation effect is one point where you should stop, or when you reach your target diameter. And so a big thing to know here is that this could require multiple sessions, and you should counsel your patient that multiple sessions may be needed. They may be frustrated after that first endoscopy if you do a dilation and they're not feeling better, and it's really important to have appropriate expectations. So in general, what we recommend is a conservative approach with small increases in diameter, and this is the start low and go slow model. So in other words, you want to start slow. As soon as you get that mucosal disruption, then you stop, you have the patient come back, you can always repeat another dilation later. And the goal should be around 16 millimeters, and that's because various studies have shown that symptom improvement is attained at that level, but also risk of food bolus impaction goes down. You can use both through the scope balloon dilators or bougie dilators, and this is strongly determined by clinician preference, so maybe what you're more comfortable with, or also stricture characteristics. So in my practice, how I do this is I tend to favor balloon dilators when it's a focal stricture, when I want a quick answer, I want to look and be done. When I use bougie dilators, it's more commonly in the patients that have diffuse narrowing or multifocal strictures, and I want to gradually increase and look at it. I'm going to show you a couple videos in a moment, and I'll talk through it at that point. But when you use your bougie dilators, you always want to go back and look between dilations because oftentimes you will not have the tactile sense of a significant amount of resistance when you're using bougie dilators. And using an initial dilator size that may underestimate your esophageal caliber and then relooking and then working to a larger size is very appropriate. And so if you're just starting off doing this, I would counsel to take that motto. It's always okay to go lower and then increase your size rather than be too aggressive up front. So these are some images of patients that I have dilated, and I use these images to show you that this is an appropriate or an adequate dilation effect. So you can see here that there's mucosal disruption, but there's not a perforation. So let's look at some dilations. So this is a
Capture resume.
video of a balloon dilation that I was performing, and you'll see in the middle there, or in the center of the screen, that you start to get a mucosal disruption at the GE junction. And then what I'm going to do in this video is, after I feel like I have adequate mucosal disruption at that location, then I'm going to pull the balloon up through the esophagus proximally towards the mouth. And this was a technique that was originally described in 2011 out of UNC, called a balloon pull-up through technique. And so what I'm doing here is I'm looking for any other subtle strictures that could have been more proximal in the esophagus that may have been missed on my endoscopy. And when you encounter those, you'll see this balloon here did not have any resistance being pulled up. But when you encounter those, you'll see there's some more resistance to the balloon being pulled up, and the lumen of the esophagus will become tight in that area. And then you can always deflate your balloon, pull it back into the scope, and then re-dilate any other location throughout the esophagus. You always want to go back and look at your mucosal disruption, even if you saw it through the balloon, just to assess it and make sure that you don't have any kind of complication. And then all I'm doing here is I'm showing that then I can subsequently replace my balloon and then go to a larger diameter and again pull it up through the esophagus to see if there's any other stricture with the same balloon size. So here I'm just inflating again to the same diameter that I already had that mucosal disruption, and then I'll gently pull the balloon back proximally so that I'm not at that same area, inflate it more, and then again pull proximally to see if there's any other stricture. And you can see I have more connection with the esophageal lumen because it's a larger balloon size at this site. I'll just comment here that also when you do this technique, you want to make sure that you never advance your balloon forward because you do have a wire and you can perforate that way. So you only ever want to drag the balloon proximally and never distally. So again, just retract the balloon and then I just go and look again to make sure I don't have any other complication. So this is an example of when I'm using a bougie dilator. And so what I want you to appreciate here, this is just the native esophagus before dilation, is what size would you start with? Where are you estimating this esophagus when you're looking at it? This is a patient that had substantial dysphagia, was actually only consuming liquids. And so then I placed the guide wire, and I actually started with a 12 millimeter on this patient. I look after each one, so went up to 13, went up to 14, did not see any mucosal disruption, and then finally at 15, this is what we saw. So you can see, obviously, you have a nice mucosal defect there. And no further dilation is needed. And this can also help you assess, like, where are your predominant strictures, right? So you can see in this case that this patient had a diffusely narrow esophagus with mucosal disruption in multiple locations. Even proximally here, you'll see one at about 12 o'clock. There have also been studies where bougie cap was used, so I just want to mention that out of Europe. It's a distal cap placement that you can place, and that also is an adequate way to dilate patients. So one final thought here is that dilation does not impact your underlying disease activity, and so while dilation is effective, it's safe, it results in symptom improvement, it decreases risk of food bolus infection, you don't want to use it in silo. So it does not change the pathophysiology of the disease or affect remodeling. And so achieving histologic remission has enhanced outcomes, and there's several studies that have shown this. One that showed fewer dilations over time when you had histologic remission, one that showed more success at reaching your goal diameter, another one that showed recurrent narrowing noted after anti-inflammatory therapy is withdrawn, and then of course more data to show that inflammation control may improve distensibility on endoflip and decrease need for dilation. And that is it.
Open to questions. Dr. Jose Silva, how do you position, I love that bullet you had about histological remission, and that does help. How do you position medical therapy in terms of dilation?
Yeah, so I do both in combination, basically. So thank you for that question, because there was one other comment I wanted to get to before running out of time, is that you can also do empiric dilations in a patient who you've reached histologic improvement on, you don't see a stricture, they're still having dysphagia, you're trying to figure out why is that dysphagia still present, and you can do dilation in that setting as well. So I use it both in the beginning, especially when patients are having severe symptoms, but I also use it throughout any endoscopy that I'm doing. If they're still having dysphagia, I will dilate them even when I'm assessing their histologic response on anti-inflammatory therapy.
So you would dilate them even though the endoscope is able to pass through?
Sorry, I'll dilate even if the endoscope isn't able to pass through?
Is able to pass
Yes, I mean, that's a very rare occasion, but you could use fluoroscopy and dilate when you can't get the endoscope to pass, absolutely. Or switch to an ultra-thin scope and then do it that way as well.
Sorry, what I meant was you would dilate even if the endoscope is able to go through, you would dilate?
If they're having dysphagia and I see, yeah, so yes, I would.
To about 18 millimeters or?
16.
16.
16, yeah,
Okay, great.
is usually my goal.
Thanks.
Great. Thank you, Jennifer. That was wonderful. I just want to, I do Maloney dilations because I don't know, Gary, if you do Maloney, and many of us, the old folks were taught Maloney dilation. You have to be careful, so thank you for the cautious words that you were using on that. But if someone has dysphagia and you dilate and they have EOE, one of the issues is that they may not come back. So one has to really emphasize that they're going to feel better and they ignore the inflammatory process, and then they don't come back till the stricture is back. They feel as if that's the treatment. So thank you for emphasizing that. Yeah.
As a clinician, that's our job then, is to obviously educate the patient as to why we're putting them on anti-inflammatory therapy, why it's so important to continue on that therapy for maintenance, which I think will be discussed in our next talk. And then also, obviously that you may feel better, you might have chest pain initially, but this will improve your dysphagia, but that's not the end result that we're ultimately shooting for. We want to see them back and have them on some kind of therapy.
Thank you so much for a wonderful talk. Alyssa Drozdak from Columbus, Ohio. I'm in the community and I see a ton of really severe EOE. So this is great. Your talk was very high yield for me in particular. My question is about balloon dilation. Do you have a particular manufacturer that you like to use, pros, cons, or something you found that you really prefer, and why?
I don't know that I have a preferred balloon per se. I think what I'd go back to is start low.
Yeah.
So if you use a smaller balloon, I mean, the most harm that you have is cost, right?
Exactly.
But you can always upsize your balloon, and you can even start, like I said, on that one, you could go 12, then 13, then 14, and you could even pull it back and say, okay, is there a stricture somewhere else that I'm missing? So I do like balloons in that aspect, but I don't have a specific manufacturer that I've tested between all of them.
Thank you.
Doug Horst from Boston. Recalling your question about avoiding risk, in a patient who has relatively infrequent dysphagia but who does have perhaps a stricture in there, is it reasonable to just treat them and not dilate and then hope that in fact their symptoms were due to dysmotility and the stricture was really not a problem?
Their prominent problem. Yeah. So I think this comes back to shared decision making. I think it depends on how symptomatic the patient is. I think it depends on if you have a plan to follow them and anti-inflammatory therapy in place. And it depends on how effective that is too. So, depending on what treatment I put them on, I may have them coming back for an endoscopy anyway. And then we can talk, hey, if the symptoms persist, then we could consider dilation in the future. Or if they get better, absolutely. So there's data to show that anti-inflammatory therapy can actually improve diameter of the esophagus. And so you may see that improvement without having to do an upfront dilation. So completely dependent on your conversation with the patient and how much symptoms they're having.
Thank you. Before we go to the next speaker, with a show of hands, how many of you use IC, that app we talked about earlier? IC, the app to, okay, thank you.
Yeah, the plug I would make for that is you could all go to the App Store right now. It costs nothing. Go to IC. It's very useful in clinical practice. It's simple, easy, and it's a freebie. To conclude this morning's session, the hardest talk to be delivered in the time allocated goes to Dr. Natalie Nguyen from the Children's Hospital of Colorado, who is going to go into medical therapy in both children and adults for EOE.
Thanks, Gary. Thanks for the invitation to speak today. These are my financial disclosures. So our objectives today will be to explore effective treatment strategies, including dietary modifications and pharmacological therapies. We'll review the role of proton pump inhibitors and topical corticosteroids, including the newer formulations. We'll discuss the role of stepping up or down in diet elimination, identify recent advances in biologics, and focus on some novel therapeutic targets that are on the horizon, and then understand specific issues that are pertinent to the pediatric population. So I'll bring your attention to this management algorithm that was recently published in the ACG clinical guideline. We'll first focus on the initial diagnosis, as I've highlighted here. If we zoom in on this part of the figure, we'll focus on the anti-inflammatory treatments, and we'll review the pharmacologic treatments, including PPI and topical steroids. We'll first talk about proton pump inhibitors. As you all may remember, that in the initial consensus recommendations in 2007 by Dr. Fruta et al. And colleagues, PPIs were used to try to first rule out reflux as a cause of esophageal eosinophilia. However, over time, we started understanding more and more about the role of proton pump inhibitors and how there was a subgroup of patients who were previously referred as PPI responsive EOE that responded to PPIs as treatment. So in 2018, at the AGREE meeting, the diagnostic criteria were updated to recommend PPIs to be considered as a treatment for EOE rather than part of the diagnostic criteria. There have been several studies evaluating the effectiveness of PPIs using various doses and duration as noted here. The pooled response rate, indicated here by the green box, shows the overall histologic response rate is about 50% for PPIs in the treatment of EOE. A number of studies have examined the predictors of response and non-response to PPI therapy. The group at Nemours has looked at STAT6 genetic variants, and STAT6 causes local expression of eotaxin 3, which is a chemoattractant for eosinophils. So there are certain genetic variants of STAT6 that increase your likelihood to fail to achieve remission with PPIs. The group in Spain found that rapid metabolism of PPIs can be a predictor of non-response to proton pump inhibitors. The largest of these studies was a cross-sectional study of 650 patients in the European EOE Connect registry that reflects real-world practice in Europe. In this study, 630 patients had induction therapy with PPIs. They found that there was symptomatic improvement in about 70% of patients and histologic remission in about 50% of patients. They also identified that younger age, less than 36 years old, lower BMI, less than 25, and higher peripheral eosinophil count, and those who had previously failed topical steroids or diet therapy were predictive of PPI non-response. So these studies have helped us to identify which patients may not respond to proton pump inhibitors for treatment of EOE. The predictors of response were the presence of inflammatory endoscopic features, led to or was shown to be more responsive to PPIs in this European study and also in some of Dr. Carlson's work. Prolonged initial therapy for at least 12 weeks, and then high dose PPI compared to low dose. So in the recent ACG guidelines, the recommended dosing for children is 1 to 2 mg per kilo. 1 mg per kilo BID or 2 milligrams per kilo daily, and then in adults, double the dose for reflux. So omeprazole 20 BID or at least 40 milligrams daily. This slide illustrates a timeline of the long history of topical corticosteroid treatment success. There were initial reports of treatment of EOE with inhaled corticosteroids in 1998, and then SEMA's group first described the use of oral viscous budesonide in 2007. Alex Drummond's group described using topical corticosteroids for maintenance therapy, and Evan Dellen's group compared oral viscous budesonide versus swallowed topical steroids from an inhaler and found they were similar in efficacy. It was not until 2018 that the European Medication Agency approved budesonide in the form of the budesonide oral dispersible tablet. And then in the United States, after heroic efforts, the FDA approved budesonide oral suspension, an esophageal pre-made form of topical steroids in 2024. Looking at many of these studies, we know that there's minimal impact on adrenal insufficiency, growth, Candida esophagitis, and very minimal side effects with topical steroids. This meta-analysis looks at many studies that have evaluated the effectiveness of topical steroids in EOE and shows a risk ratio of 12 when comparing topical steroids to placebo. These are the most common formulations of topical steroids that are typically used. Budesonide is commonly used using a mixing agent such as Splenda, or we often use Neocate Nutra to create a viscous budesonide slurry. This is often used in pediatrics to mix because some children at young ages can't do the technique required to swallow an inhaler. The oral budesonide, the oral dispersible tablet is available in Europe, and then the oral budesonide suspension is available in the US now. It comes in a packet that you shake, open, and swallow, so it's pre-made. There are also several inhalers that are used, including fluticasone and ciclosinide, where you can take the inhaler, puff it, and swallow the medication to reach the esophagus. The ACG guidelines highlight dosing for these different formulations. And in pediatrics in particular, young children under the age of 7 or 8 may not be able to do the technique of swallowing the inhaler, so we often use budesonide viscous slurries in those children. We'll now shift gears to talk more about diet elimination treatment for EOE. There's a long history of diet treatment success. Initial studies in 1995 by Kelly et al. Helped us understand the pathophysiology of EOE. They noted in their report that there were a group of children who were thought to have reflux, who had esophageal eosinophilia, who responded to 6 weeks, or at least 6 weeks of elemental formula, suggesting that food allergens may play a role in the pathophysiology of EOE. Dr. Spergel and Leah Corris's group from CHOP in 2002 started to evaluate the role of food allergy testing in EOE, and subsequent studies highlighted here have focused on empiric elimination diets, such as the 6-food, the 4-food, the 2-food, and the 1-food elimination diet. The group in Spain were really pioneers in considering step-up therapy when we think about stepping from a 2-food to 4-food to 6-food elimination diet, and how this might decrease the need for endoscopy and a less restrictive diet, because we know that most people have 1 to 2 food triggers in EOE. As we better understood that testing-directed diets were not very effective in the treatment of EOE, our approach really focused on empiric elimination diets. So after the removal of the 6 foods, we would recommend an endoscopy to assess what things looked like histologically and with symptoms. And then you would sequentially add back a food and undergo endoscopy. This can be time-consuming and affect quality of life, as the diet is quite limiting, and may require many endoscopies to identify food triggers. Subsequent studies have looked at empiric elimination diets, which the one food elimination diet is the elimination of dairy with an efficacy rate of 35 to 45%. The two food elimination diet, eliminating dairy and wheat with an efficacy of 40 to 45%. The four food elimination diet, avoiding dairy, wheat, egg, and soy, somewhere between 40 and 50% efficacy. And then the six food elimination diet, dairy, wheat, egg, soy, nuts, and fish and shellfish, somewhere between 40 and 70% effective. Allergy tested directed diets have really fallen out of favor and are not recommended. And elemental diets, I think, have a huge impact on quality of life, which needs to be considered in a chronic disease. So given this data and recent important studies looking at the efficacy of 1, 2, and 4 food elimination diets, some have changed the approach to consider starting with a less restrictive diet. For example, starting with the removal of milk and wheat, and then considering endoscopy, and if active EOE, then stepping up to the 4 food elimination diet. I think diet elimination certainly highlights the importance or advantage of working in conjunction with colleagues in a multidisciplinary setting. For example, working closely with dietitians and allergists to think about, what other restrictions patients with EOE have, what micronutrient deficiencies might come up with avoiding this many foods. There are certainly barriers to diet therapy, including thinking about their additional food restrictions, as we know that patients with EOE have other atopic comorbid conditions like food allergies, thinking about multiple endoscopies that patients must go through, thinking about how this affects their lives socially, so going to dinners, events, birthday parties for children can be very difficult when you're avoiding milk, wheat, soy, egg, for example. There are nutritional risks that our dietitians think about and help us to consider. There are studies looking at the cost of diet elimination when we think about avoiding all of those foods. And then also patient anxiety of when they're out at restaurants and out at social events of not knowing if these foods are hidden or trace amounts in foods. So we'll shift gears now and talk about how to think about positioning biologics. So we've moved through the anti-inflammatory portion of treatment options. Jennifer talked about stricturing and dilations, and so now we'll focus on how do we consider biologics in this realm. As we talk about biologics, I'd like to point your attention just to focus on the pathophysiology of EOE and how these biologics play a role. Food allergens induce inflammatory proteins and cellular receptors, which activates these immune cells, highlighted here, and leads to esophageal inflammation, lamina propria fibrosis, esophageal dysmotility, and epithelial permeability that has been highlighted by many of our co-speakers today. As you can see, it's been a long road of research to the approval of dupilumab. IL-4 and IL-13 were first described in the 1980s and 1990s. And then in the early 2000s, we first understood that IL-13 played a role in the pathogenesis of EOE. All of this work culminated in large multi-center trials for dupilumab, which was approved for the ages of 12 and up in May of 2022, and the approval of dupilumab down to the age of 1 just in January of 2024. So dupilumab is a human monoclonal antibody to the IL-4 receptor. It acts to block the IL-4 receptor alpha subunit, which is shared by both IL-4 and IL-13 receptors. As a result, it downregulates Th2 inflammatory markers as an effect in EOE. This is the landmark study that was published in 2022 looking at dupilumab in adults and adolescents. In parts A and B of the study, or in parts A of the study, patients were randomized to either dupilumab 300 milligrams every week or placebo. And in part B, they were randomized to either dupilumab 300 milligrams every week or every 2 weeks, or to placebo. Part C was the open label extension, where patients subsequently received dupilumab every week or every 2-week dosing. The results of the study showed that 60% of patients achieved histologic remission on dupilumab weekly versus 5% with placebo. In Part B, when you compare dupilumab weekly versus every 2 weeks, we saw that similar results with histologic remission. There were about 59 to 60% responded histologically to dupilumab versus 6% with placebo. And finally, in Part C, similar histologic results. Interestingly, in regards to the dysphagia symptom scores, we saw that with every 2-week dosing was not statistically significant from placebo, but every week dosing showed improvement in symptoms. In terms of adverse events, the green box shows that very few adverse events led to discontinue of the medication, and the most common adverse event was injection site reactions. All the injection site reactions were noted to be mild to moderate in intensity, and none of the serious injection site none led to permanent discontinuation of the drug. The EOE Kids trial was subsequently done looking at high exposure to dupilumab versus low exposure to dupilumab, and found that histologic remission was seen in 58 to 68% of patients on dupilumab versus 3% on placebo. So how do we position dupilumab? An expert panel published some considerations on when to consider dupilumab as first line versus as step-up therapy. They suggest that patients who have multiple comorbid conditions, including asthma, eczema, and nasal polyps, should be considered. Patients with a strong preference to avoid dietary restrictions or topical steroids. In thinking about how to step up in therapy, contexts to consider dupilumab include when EOE is difficult to treat, when patients have failure to thrive or poor growth, and weight loss due to EOE, patient with frequent use of rescue therapies, patients with severe diet restrictions requiring amino acid-based formula, patient with clinically significant strictures or narrow caliber esophagus, or patients who are refractory to their current therapy, or patients with adverse events to their current therapy. So there are many novel therapeutic targets that are on the horizon. Cendakimab is an anti-IL-13 that has completed phase 3 clinical trials, and there are presentations here at DDW highlighting the safety and efficacy of cendakimab. There's anti-TSLP that is currently in phase 3, and there are certainly case reports that are describe anti-TSLP in the treatment of EOE. There's anti-KIT that targets mast cells in phase 2 trials. There's S1P receptor modulators in phase 2 clinical trials. There are alpha-1 antitrypsin inhibitors in phase 2 trials currently. There are anti-IL-15s in phase 1 trial and JAK1 inhibitors that are in phase 1 trials for EOE. And then vedolizumab has been described in case reports for treatment of EOE. Again, not in clinical trial currently. So a few pediatric considerations. I know that in adults we use IC and a lot of other thinking about fibrostenotic phenotypes, et cetera. But I think in pediatrics, we do consider the severity of disease may include other factors, such as height and weight and growth overall. We also think about development and eating, children and their eating skills, and then their nutrition, the proper intake of nutrients when thinking about diet elimination. I think quality of life should be considered for both the patient and family when considering management of children with EOE. And right now, while dupilumab is approved down to the age of 1, it does require a weight of 15 kilograms. So there is a gap right now that remains for children who are under 15 kilos. So in summary, in thinking about our treatment paradigms in EOE, I think right now we are in a phase where we think about stepping up or step-up therapy in thinking about proton pump inhibitors, diet elimination, or topical steroids as first line. As we think about non-response, we think about switching therapy. I think we also consider combining therapies of proton pump inhibitors, diet, and topical steroids. And finally, at the top, we think about biologics. In thinking about this paradigm and comparing it to inflammatory bowel disease, it remains to be seen how our treatment paradigms may shift as more biologics come out and as we understand more about the natural history of the disease. Thank you so much.